The broadcast is now starting. All attendees are in listen-only mode.
Hi, folks. I'm going to apologize. For some reason, I think you all were on mute, so we're going to begin from the beginning again. My apologies. Your phones are all muted. You may ask questions at any time, but we will be collecting those questions to be answered at the end. FORCE is a national nonprofit dedicated to improving the lives of individuals and families affected by hereditary breast and ovarian cancer. FORCE programs include providing support, education, advocacy, and information on the latest research. We have a variety of programs, including toll-free helpline, conference, free brochures. We have over 50 local outreach groups, a newsletter, the Be Empowered webinar series, our message boards, a post-mastectomy photo gallery for individuals interested in learning about their mastectomy reconstruction options. We also are very involved in research and advocacy. Today, we're going to do a little bit of our brief introduction, and then we will introduce Dr. Bober. She'll go through her presentation, and throughout that, we'll be taking questions. You can use the questions panel or the chat panel, and then we will attempt to answer all of your questions at the end of the presentation. Again, FORCE has a variety of ways for you to stay in touch. We have our 866 number helpline in both English and Spanish. You can visit and participate in our message boards, sign up for our outreach updates and e-news updates. We're always looking for volunteers. And then you can contact us at info@facingourrisk.org with any questions, concerns. In the social media world, we are on Facebook and Twitter, so please follow us. Clinical trials and research are a very big part of what FORCE does. We're dedicated to engaging in research and helping recruit research participants in studies that will benefit our community. This is just a sampling of the studies we're involved in at this point, and you can find this on our website. Brocade is a specific study I'd like to call out. It's a large clinical trial studying PARP inhibitors, specifically veliparib, for advanced BRCA-associated breast cancer. This study is open at many sites within the U.S. and internationally, and if you visit brocadestudy.com, you'll find more information and a list of open sites. Another study we'd like to call out is being conducted by the Baster Research Center for BRCA. If you've had your ovaries removed to prevent ovarian cancer, they are studying this and asking individuals with BRCA1 and BRCA2 mutations to share information about their quality of life since this surgery. The study is completed entirely online and will include questions about sexual, physical, and psychosocial health. You can access the survey at this URL here at tinyurl.com/RRSO-study. And of course, there's a phone number and an email address for additional information. Again, all clinical trials that we're tracking are available on our website in the Clinical Trials and Research section. After this webinar and after the questions, you can expect to receive a survey that will be emailed probably within 24 hours. We would very much appreciate your feedback on the webinar, on the topics covered, and possibly on topics that you would like covered in the future. Your feedback helps us continually improve this program, and we always appreciate any input you have. So we're going to go on to the webinar now. Thank you for joining us. Body image and sexuality after surgery, cancer, and or treatment for survivors and pre-vivors. Yes, we know that's a mouthful, but it's such an important topic, and it's kind of a topic that everybody thinks about, but not too many people talk about. Dr. Sharon Bober, on the other hand, is somebody who doesn't mind talking about it, and she is dedicated to helping our community with this issue. Sharon Bober is the founding director of sexual health, of the Sexual Health Program at Dana-Farber Cancer Institute, and she's associate professor in the Department of Psychiatry at Harvard Medical School. Her clinical and research efforts focus on sexual health, cancer survivorship, and developing effective methods and models for sexual rehab intervention for cancer patients and survivors. She currently lectures quite a bit to clinicians about how to address sexuality with medical patients and is involved in a great deal of research on this topic. So I'm going to hand the controls over to Dr. Bober, and she will go through the presentation. And again, if you have questions, please forward them, and we will gather that information and ask the questions at the end. Thank you.
Okay, Lisa, thank you so much, and it is really
Hold
a
on
pleasure to be
just a
here.
moment, Sharon. We are
Okay.
transferring controls over to you.
Okay, you let me know.
Okay, let's see. Is your screen up?
Yeah, it is.
There you go. Okay, wonderful.
Okay, thank you. Great, so are we ready to go?
We are.
Oh, okay, so it is a pleasure to be here today and to talk with all of you really about this topic that Lisa just mentioned that is often on everyone's mind, and I spend plenty of time with women who say to me really first thing is that, I know I should be just grateful to be alive and be here today, and we all are. But at the same time, I'm feeling really frustrated about my sex life, and that is a very common complaint. And it is really important to be able to acknowledge that this is a very important central quality of life issue. So, just to sort of begin with, it's really okay and more than okay, but valid and important to take time to focus on sexuality and intimacy and issues of body image. The World Health Organization has now recognized sexuality as a fundamental human rights issue. And I'd also argue that besides the fact that this is about quality of life, sexual dysfunction, we know is related to things like anxiety and depression and stress, but that actually when we can get intimacy and sexuality kind of back on track, we also know that it is something that can relieve stress and that can maintain a sense of connection and can really sort of facilitate the experience of recovery. So there are all kinds of reasons why it's important to take time to focus on this issue and figure out what is not going right, so we can also then figure out how to get things back on track. So one of the the issues here, which I would say sort of more like the cultural context, I really often start by talking about, because we live in a funny culture. Everybody talks about the fact that, think about the recent conversation about Miley Cyrus. We live in a culture which is really saturated with graphic images and sexual images, but there is paradoxically very little real conversation about real sexuality, and that often, especially and interestingly in a medical context, it seems like lots of people feel anxious about talking about it. So often there's some, essential confusion about who's even responsible for initiating the conversation. When we ask clinicians why it doesn't get talked about, people will say, well, I don't want to make, my patient uncomfortable, so of course I'm not going to bring it up. And then when we talk to patients, people say, well, often I can tell my doctor's uncomfortable. That's the last thing I want to do is make him or her more uncomfortable. So there's often this kind of funny stalemate that nobody even knows how to start the conversation. And there are lots of assumptions and often kind of misinformation. So, it's important to acknowledge that if this is something that's a struggle for you and that's not getting talked about in sort of your medical context or with your providers, that it's not your fault, and that this is very much one of the common challenges that we have. The other sort of factor I'm just going to throw in there is that often clinicians themselves aren't sure what to say if a patient endorses a problem. So one of the things that we are also doing in terms of the research and intervention work is to work with clinicians to give them tools, give them strategies to be able to pass along to patients, because obviously no one wants to bring up the topic of sexual dysfunction if you're not sure kind of how to deal with it. So moving along, I also want to maybe take one other step back just to say, what is sex? What do we mean by sexuality? And I say this because often the common sort of definition or meaning people sort of think about is whether you can have intercourse or not. And that really beyond the fact that sexuality is a very sort of fundamental and life-affirming element of human experience that goes across the lifespan, it's really much more than just intercourse or some kind of physical encounter that leads to intercourse, but that when I think about sexuality, I'm also thinking about not just the body, but the mind, our feelings, our experience of ourself, our behavior, our identity, our sense of ourselves being sexy or sexual. It really is mind and body, and for many people also a spiritual experience, but it is certainly more than just the physical experience of intercourse. And so thinking about it in a sort of a broader sense is important. Also realizing we always have to put things in a context so that your experience of sex and sexuality now is obviously informed by things that have happened before, expectations about the future, and that most importantly, there is a wide and varied range of normal function. So many people will say, well, what's normal? And the most important point here is that normal is what is normal for you. So, there is certainly a varied and wide range of importance that individuals will place on sexuality. For couples that are, not sort of active, sort of in a very physical sort of way, but feel very close and are not distressed, then it's not a problem. So, this is to say that if it's a problem for you, then it's a problem, and that the goal here is not to figure out what is normal, but it's to figure out what is the goal for you. And so that's really where we have to go from there, okay? So then the next function here is to sort of then think about what does sexual dysfunction mean in the context of survivorship and previvorship, and really to understand that often sex is one of the first aspects of sort of normal experience that often gets disrupted for both our previvors and survivors. And unfortunately, the majority of our previvors and survivors will also tell us that unfortunately they didn't have a lot of preparation in dealing with these changes, and often expectations were sort of not sort of set from the outside. So certainly sexual problems are very common, and I'm not going to belabor the details of the next slide, but just to say that, we know the majority of breast cancer survivors report at least one long-lasting sexual health problem. We know that the great majority of women after GYN cancer often struggle with some kind of severe sexual changes. And also our previvors report disruption in sexuality. Obviously going through prophylactic surgery has enormous impact, but often previvors get very little attention because of this issue. And often because they don't have cancer, they're even sort of more marginalized from this conversation. And, just putting things in perspective, we know that sexual dysfunction is a big issue and a distressing issue for many cancer survivors. So, what does it actually mean for us? Well, what does it mean in terms of women's own words? Often women will talk about feeling like they've been neutered. Often women will talk about feeling somewhat cheated or angry because it's something that often is on our mind every day. Some of the quotes here, I'd rather just read a book. I've really lost all interest. I feel really busy with kids and working, and I'm not sure there's anything that can be done anyway. So that sense of just not knowing if there's anything that we can do to improve the problem. For younger women, a quote here, my older sister thinks she understands, but she has kids, she's married, she really has no idea. And then also very importantly to recognize that women who are single, women who are divorced, women who are widowed are still sexual creatures and beings and need to address the issue, but often don't get asked about it because the assumption is that if you're single, if you're older, if you're divorced, etc., then you're not sexual and it's not relevant, and that is a great misunderstanding. So again, just the sort of larger perspective in terms of the model, when things are on track here, mind and body and relationship, ideally sexuality and intimacy, things are on track and things are sort of going along. When there is some kind of disruption, when there is some kind of challenge or problem, whether it is with body, with mind, with relationship, or any or all of those three things, then we typically find that things get off track in some way. So the basic perspective in terms of rehab is to figure out where things have gotten off track, whether it's in any one or all of those domains, and then to figure out what we can do to sort of address the issue. And also just to clarify that when we think about sort of why this is happening, you know, every type of cancer and cancer risk-reducing treatment, you know, potentially has a direct impact on sexuality and intimacy, including body image. So again, whether that's surgery or chemotherapy or radiation or hormonal therapy, all of those tools, which are often very effective in managing cancer, unfortunately can cause disruption in any of those domains that we just talked about. And also just to say that, you know, believe it or not, sexual rehab is not provided in the vast majority of oncology treatment settings. So women are often feeling very alone on this topic. In terms of who's at increased risk, certainly if you have struggled with sexual problems before treatment, women who are younger, typically who have been premenopausal before treatment and have then gone into menopause because of treatment, they are at increased risk for challenges. Women who have a history of depression or anxiety, women who currently or previously had relationship difficulties, and women who are not partnered are all folks who are typically at increased risk for some challenges in this area, and we need to be very sort of mindful about that. So, you know, laundry list of common problems. What I really want to do is take time to talk about how you deal with these. But whether we're talking about changes in body image and self-esteem, whether we're talking about premature menopause, we are also maybe talking about pain. Decrease in physical responsiveness, arousal is just not the same as it used to be. Difficulty reaching orgasm and desire are probably the main problems that we deal with in clinic every day, and some of the problems that I want to address today. So first and foremost, just sort of thinking about the issue of body image and self-esteem, it's very important to acknowledge that this is something that is certainly informed, obviously, by past history, as well as our current experience and certainly the assumptions about the future. And that, you know, more recently, I think we have a sense that especially issues like body image can become actually more pressing over time, not less. So, for example, sometimes there are issues or challenges that women have, for example, around anxiety or depression that are obviously very sort of profound around the time of treatment, but sort of get better over time. And interestingly, the issues around body image and sexual dysfunction, many of those issues do not necessarily get better by themselves over time, but in fact can become more distressing unless we do something about it. Also for women who sort of have advanced cancer, who are dealing with physical side effects like lymphedema, who are struggling with feeling sedentary and lack of physical vitality. And again, for women that are really just struggling with the relationship piece, we know that body image and self-esteem suffers. And so this is not a minor issue, and it's something that really needs attention. Also to talk about, just looking at my, to talk about the kinds of things that impact body changes and body image, you know, sometimes there's a lot of attention on the kind of obvious physical changes. So we talk a lot about mastectomy and surgical reconstruction, scars and skin changes, and those are very obvious. But I think sometimes the changes are not quite as obvious and yet are still profound. So, you know, when we have, for example, loss of sensation, you know, when women are dealing with, you know, mastectomy and reconstruction, and people are saying, you know, ultimately, gosh, you know, things, you know, reconstruction looks terrific, that is huge in terms of helping with self-esteem, but there is still profound loss often when you just don't have any nipple sensation, and for many women that is a huge part of how to have arousal and how to reach orgasm. So for example, we need to sort of help women kind of remap their erogenous zones in order to figure out and rediscover sensation in other parts of their body that will allow them to have arousal, because that loss of nipple sensation is huge, and that's something that doesn't often get acknowledged in any kind of public way, especially when we talk a lot about reconstruction and how good it might look, but that it doesn't really address or validate that sense of loss. Also, I think around just the experience of losing one's reproductive function, what it means whether you're sort of premenopausal or postmenopausal, to lose one's uterus, to lose one's ovaries. Often that just has a real core impact on that experience of identity, of what that means to feel feminine, whether one is finished with childbearing or not. But that, again, is something that is not obvious. That's not something that's often talked about, but that has a real impact on how people feel about themselves. And also, I think, it's just important to really sort of underscore that when we feel unattractive in some way, when we feel that there's a flaw or we feel defective in some way, it clearly has an impact on our self-esteem, and that's hard to talk about this stuff. It is embarrassing. It can feel shameful. Women can feel guilty. You go through all of this in order to save your life or in order to get well so you can be alive for your family, for your friends, and the feeling that you're still feeling a sense of loss or frustration or anger often doesn't get, there isn't space for that in our kind of social sort of communications with people about the experience of being a survivor or pre-survivor. So it's hard to talk about. And the fact is, desire, libido, can be very much impacted by all of that. So when we don't feel good about ourselves, or when we don't feel whole, or when we don't feel sexy, it's also going to have a real impact on the experience of desire. So I will come back to talking about what we can do about some of that, but I want to sort of also now sort of switch a little bit to the body, because that's so much a part of the experience of sexuality. And then again, I will come back to talking about the issues of self-esteem and body image. Probably the #1 issue that we have to deal with in terms of sexual dysfunction really has to do with disrupted ovarian function. When women are kind of sort of launched into premature menopause, when there is impairment of ovarian function, whether that's from chemotherapy or surgery or hormonal therapy, it has a very major impact. So whether that's going into menopause for the first time, or whether that's a sort of an increase in menopausal symptoms for women who have already gone through menopause, those symptoms can often be very dramatic. Menopause experience can be very unpredictable, and for the majority of women who go into treatment-induced menopause over the age of 35, the majority of those women will stay in menopause. And in terms of sexuality, some of the obvious symptoms that are related to that have to do with, that sort of abrupt loss of estrogen. So clearly there are hot flashes and night flashes, but really vaginal dryness, burning, itching, chafing is a very important issue that we will address today. This can also then be related to decreased arousal, frustration, or difficulty in reaching orgasm. When women lose their ovaries, they lose about half of their androgen levels, and fertility-related distress as well. So let's talk about vaginal dryness, because this is something that's a very common problem. I think does not get nearly enough attention. We know the vagina really thrives on estrogen, and that lack of estrogen can lead not just to dryness and tightness, but the tissue can really become quite thin and can tear quite easily, and that when you don't have that natural moisture that comes from the estrogen levels being what they are, you also lose the mechanical stretch in that tissue. Over time, the tissue loses its flexibility, and then certainly any kind of penetration can become quite painful. And the fact is, and I always say this, if you've had sex one time and it really hurts, you're going to have a desire problem. Why would you want to keep trying if sex is painful? And for lots of women who have had the experience of discomfort or pain during sex, there often very quickly becomes a secondary issue of kind of muscle tightening. The pelvic floor muscles kind of start to naturally guard and contract, and that can itself become a syndrome called vaginismus. But it's really sort of just a kind of a clear pain cycle. And so we really need to make sure that we address this issue of vaginal dryness before women sort of go down that road of having muscle tightening and vaginismus and pain, because then, it's a tougher road to have to go back. Also, just to say that it's not just about sex. I saw a woman yesterday in clinic who talked about the fact that, although she's 56 years old, she has to get a PD speculum for a GYN exam because it's so painful to get a basic GYN exam. So, there's a lot of reasons why we want to try to address this issue of vaginal health. And so, what do we do about it? Actually, sort of take one more step back. Also, for women on hormonal therapies, particularly aromatase inhibitors, the vaginal dryness issue is huge. In terms of tamoxifen, the results are actually quite mixed about sexual function. Some women do find that dryness is a problem. Many women on tamoxifen do not. But we know that for women who are on an aromatase inhibitor, the side effect profile in terms of menopausal symptoms is really pretty severe. And so women do talk about not just dryness and dyspareunia, which is pain, but we really see ultimately what can lead to something called vaginal atrophy, where we really lose that stretch and the sort of lack of blood flow and moisture in that tissue. So all the more reason that it just means we have to be active about replacing those issues, those elements. So the kind of perspective that I'm going to take in dealing with these issues, and we're going to get into that right now, is really kind of an integrative model where we sort of really talk about mind and body and the relationship with the other, with relationships both present and past. And so whether we're talking about vaginal health and overall well-being, whether we're talking about sort of our thoughts and our feelings and what motivates us, and or the relationship piece, I think it's really important to take an integrative perspective in order to address these issues. So thinking about the body, I often say that we have to start with the body. It's so important to restore sexual health in the context of overall health and well-being. So thinking about the mechanics, as I just said, starting with vaginal health, we will talk with women about these issues of replacing moisture and blood flow and stretch to that vaginal tissue in order to get it healthier. It's really important to realize that sexual health is always, again, in a larger context in terms of overall health and well-being, when we feel like we have energy, when we feel like we have vitality, when we don't feel tired, when we feel like we, have the kind of just vim and vigor to want to sort of get through the day, that's also going to help us in terms of feeling sexy again and feeling like we have energy for sexuality. So it's really important to think about the body in that context and sex in that context. Also thinking about body image and how we feel about ourselves. It's really important to also think about just feeling a greater sense of self-efficacy. When you go through cancer treatment, you often feel so disempowered, and I know that organizations like Force work very hard to help women feel more empowered, but the fact is going through the medical experience of cancer treatment or risk-reducing surgery, often so much of that just feels sort of disempowering, or, you kind of sort of feel like a cog in the machine. And part of what we're talking about in terms of when you come out the other side of it is also to feel like you can take back your body, you can take back your sexuality, you can revise that, you can remap that, and that part of what you need to do is figure out, for example, how to remap your body. What parts do have sensation, what does feel good, what parts of your body have you maybe never paid attention to before that need attention now, or that will allow you to feel sensation or pleasure. These are the kinds of things we need to think about in terms of the body. So again, specifically thinking about vaginal health, I want to sort of talk just quickly about these points about moisture and stretch and blood flow. It's so important to be able to sort of have a good sense of how to manage the menopausal symptoms. Thinking about vaginal dryness, which again can lead to pain very quickly, it's really important that women are aware and knowledgeable about using vaginal moisturizers as well as lubricants. We often think about, people say, oh, you need to use lube. Lubricant is a kind of a topical glide that allows you to sort of have sort of slipperiness when you're having any kind of friction or penetration, but that's different than a moisturizer, which is a product that is like a moisturizer you put on your face before you go to bed at night, something that can soak into the tissue and get absorbed into that tissue and hold water over time. So in terms of what kind of moisturizers there are out there are actually several new products on the market that are quite good. Many women have heard of something called Replens. There's also a terrific product out there now called Hyalogyn, Hyalo-gyn, also something called Luvina. But essentially, all of the vaginal moisturizers work the same basic way, which is to sort of hold water in almost like a bioadhesive gel and sort of hold that in the vaginal tissue in order to replace the moisture that you have with that loss of estrogen. And these are non-hormonal moisturizers, so that's important to know about. Typically, it is also important to then be able to think about a lubricant. So separate from a moisturizer, if you are going to use anything to penetrate, it's important that you use a good lubricant, preferably one that is water-based or silicone-based. I typically recommend it be glycerin-free because glycerin can promote a yeast infection if you're vulnerable to that. Also important to think about the fact that lots of women find that their skin is much more vulnerable or irritable sort of post-menopause, and that sometimes many of the kind of lubricants out there that are sort of billed as for being, for example, warming lubricants can really feel quite painful and can be very irritating. So often sort of going with something sort of more natural and water-based is often a good bet. And then also to realize that, you know, the tissue around the opening of the vagina, around the introitus, the perineum, all of that tissue can become very tight and dry, and it's perfectly fine to use some kind of a topical moisturizer that you can massage into that tissue, especially around the opening of the vagina. So often women find that using a little bit of vitamin E oil, pure coconut oil, even olive oil, can be very helpful. Because if you think about it, when you insert something into the vagina to moisturize inside, it doesn't really sort of get at the tissue around the opening of the vagina, and so it's important to know that you can use something to moisturize that tissue. Also, we'll just make a comment that there are also vaginal estrogen supplements, which are very effective. This is something that I always recommend everyone needs to speak to her doctor about this, but that certainly we are often very comfortable using a vaginal estrogen in order to deal with vaginal dryness, which is quite severe and may not be adequately managed with a non-hormonal moisturizer, and this is a supplement in which there is very, very little systemic absorption. So there is a very small amount of systemic absorption, and this is where obviously everyone needs to speak with their physician to make that decision. But the vaginal estrogens often sort of are used, even if they're used just short term, in order to help women get that tissue sort of healthier, and then maybe women will switch over to something non-hormonal. Different possibilities, a ring, a cream, or a tablet that can be inserted, but just know that that's a possibility. I'm not going to take really any time to talk more specifically about hormone replacement, but just to say that it is for many women, it feels like a quagmire or a quandary. And I just want to say that there is very little evidence at this point that testosterone replacement is a panacea. There are many women who say that it's helpful. There are many women who say that it is not. And when we look at the small amount of randomized control trials that look at testosterone supplementation for sexual health, we also know that there is a pretty big placebo effect. So that this is to say that, I think every woman has to sort of make that decision about hormones with her physician. But I think my perspective is this. Women's experience of sexuality is way bigger than their hormones. We know that young women who have hormonal levels intact often talk about sexual dysfunction, and we know that many, many women post-menopause have very strong sexual function intact. So, just to say that it's not something that I think if you could only take hormones, then everything would be fine. I think that's not the case, and I don't want anyone to feel like because you can't take hormone replacement in terms of overall hormone replacement therapy, that is definitely what's going to make the big difference in terms of being able to get sexuality back on track or not. So also thinking about how to deal with this issue of loss of stretch, I think it's really important to know that there are many, many ways which we can help women deal with the pelvic floor muscles. There actually are a whole bunch of pelvic floor muscles which often we don't think a whole lot about. But the fact is, if we can learn how to relax them when we need to relax them, if we can learn how to tone them and strengthen them when they need to be stronger, it is hugely helpful in terms of optimizing stretch and managing pain. Many women have never heard of something called pelvic floor physical therapy. Just going to throw that out there as another strategy for you to be aware of. For women who are struggling with pain and who are not getting anywhere by just being able to use a moisturizer or lubricant, it's probably about atrophy, and there's a need for some mechanical manipulation of that tissue to help get some stretch back. Sort of no different than when we think about doing PT after a car accident or after a knee replacement. And there are a wonderful group of very highly trained physical therapists who just work on the pelvic floor. So if you live in a city where there is physical therapy, my guess is that there's probably someone who's specifically trained to do pelvic PT, and you can always speak with your PT group and ask who in your town or city they know of who does the pelvic floor work. I know here in Boston we work with several groups of pelvic PTs, and they are phenomenal, and women often talk about the fact that it almost feels like it was magic. Obviously it's not magic, but that is a fabulous resource that many physicians as well often are not informed about. Also really important to think about what we can do to increase blood flow for vaginal health. Often we talk about the fact that, you know, there might be some tightness or pain, and we certainly think about this a lot with our men after prostate cancer and what we can do for penile rehab and getting blood flowing, but it's just as important for women to think about restoring vaginal health, to also be thinking about increasing blood flow. So, you know, the picture on this slide really is of a small clitoral vacuum pump. Actually, it's the only device approved by the FDA to help get blood flowing. But the fact is you could use a vibrator, which is what we typically recommend. You could self-touch and masturbate. But the point is that what you do want to do is try to get blood, fresh oxygenated blood flow to that clitoral tissue, because that's going to be very healthy, and that's going to be very important for the tissue, especially to help that tissue maintain health, so that you're going to be less likely to have some atrophy. There are several different kinds of vibrators, lots and lots of options if you look online, but the main point here is that typically what women find is that if there's some kind of clitoral sensation which feels good, and however you do that, that's your choice, but it's the feeling good, the pleasurable sensation also is what's letting you know that you have good oxygenated blood flow to that tissue. And so as to whether you actually reach climax or not, that's not so much the issue as much as you want to get the experience of pleasurable sensation, which means that you do have blood flowing there. And so the last piece, just in terms of the vaginal health piece I want to mention, is that, you know, women also can use a set of dilators, which are essentially stretchers, right? They are a kind of a cylinders which can sort of stretch tissue if you are having any pain or discomfort, in order to help you slowly but systematically stretch that tissue. Women can use that dilators by themselves. Women can use them with a pelvic floor therapist, but this is probably sort of one of the major tools in the toolkit in terms of regaining stretch and elasticity if you are having atrophy or pain. So just to be aware of that. I want to move on to talking about things like mind and body and emotion, because when we think about sex and when we think about image and self-esteem, it's just so important to understand that how we think has an effect on how we feel. The kind of automatic assumptions we make that we are often unaware of so much guide our experience of ourselves in terms of feeling good about ourselves, feeling sexy versus feeling flawed or feeling uncomfortable. And it's so important that we also help women feel that they have choices, that they feel greater sense of self-efficacy in terms of regaining, taking their bodies back and taking sexuality back. So that's a big part of the kind of treatment that we do as well. And also to say that the relationship piece is huge. So if you're in a relationship and things are not going well, we have to figure out how to help you communicate about this topic, how to bring it up in a way that feels comfortable versus feeling embarrassing or feels uncomfortable that you're going to make your partner feel bad. And I apologize for the picture. I don't mean to be sort of heterosexual focused here, but just to say that it's really as much a couples issue as it is also an individual issue. So sort of planning to incorporate a partner into counseling possibly, or to sort of invite a partner in to doing a set of exercises, for example, something called Sensate Focus, which just allows a couple to take their time over the course of several weeks as sort of non-sexual touch, non-genital touch, to really sort of take the pressure off and figure out how to start touch and how to start talk and how to start communicating again in a way that allows you to kind of really, in a sense, have a new chapter instead of just trying to do what you used to do and finding that it's not going very well. And I do want to say a little bit about desire, because it's such a common problem, and it's a laundry list of factors that go into it. When we're tired, when we're stressed, when we feel unattractive, when we have pain, all of these things are ingredients in that recipe, and we need to figure out how to sort of, what are those ingredients that are missing or different in order to sort of address the issue. But the good news is that you can get your groove back. You know, we can improve desire. You know, no, there is not a pill for that. The big pharma has been looking for, has spent billions of dollars, millions of dollars looking for sort of the sort of Viagra equivalent, but they haven't found it, and that's partly because women's sexuality is complicated, and that's good news and bad news. But good news is that because it's about emotion and cognition, as well as our body and our hormones and our relationship, that being able to address and change any of those things can have an impact on desire. So then when we start with acknowledging the changes and accepting the sense of loss, or sort of validate the things that are different, it then gives us a chance to really embrace this is an opportunity to chart a new course, and that it's really an opportunity to expand our repertoire. And so when we start by shifting the focus from sex to pleasure, and we really focus on figuring out what is sensual and what feels okay and what might you've not tried before or done before but feels good and allows you to be curious about yourself and your partner and your sensation, it allows us to then be optimistic to know that we can sort of really think about this again as a new chapter, so that the goal is often not to just do what we used to do, but to be able to sort of broaden our experience of sexuality and to chart a new course. So, for example, something like what we call body attunement, sort of figuring out after you've gone through treatment, whether it's risk-reducing surgery or cancer treatment, and you often feel sort of numb or almost distant for our body, it allows us to start to say, how do we kind of integrate things again? How do we come back to sort of reconnecting all these pieces? How do we sort of integrate the mind and body experience, where we sort of focus on, again, sensation or pleasure that's not pressured, that's not goal-oriented, that's not focused on whether we have sex or don't have sex, but we sort of get outside of those old habits and we start from scratch. You know, typically women do need more increased sensation, different kind of stimulation. Maybe it takes longer, maybe it's different. You know, we need to figure out what that's going to look like. And the value of being able to relax into sexuality rather than just feel anxious is huge. So, you know, maybe we're talking about mindfulness, muscle relaxation, body scan exercises, all the different ways that we can kind of harness the mind to help us relax into an experience that's often become quite anxiety-provoking. So we need to kind of remap that. And then again, sort of using sort of self-touch vibrators just to sort of think about how to reclaim our bodies again. So often this is not in the context of a relationship, but just in terms of self-care. That's sort of how we think about it. And then again, to say that the mind, the power of the mind is enormous. So being able to harness some of that power by, you know, really kind of cueing ourselves. For example, the idea of, when we feel kind of numb and when we don't feel very sexy, we also just don't notice a lot of things. And what it would mean to sort of reconnect with our senses in terms of even what's around us. Noticing someone standing in line at the bank, oh, that person is nice looking, or oh, that smells good, or oh, that tastes good. Just being able to sort of get back into one's senses. Maybe that's with guided imagery. Maybe that's with mindfulness. Maybe that's with relaxation exercise. Maybe that's with erotica. There's a lot of women, sort of pro-sex, pro-women erotica that is, whether that's visual or whether that's written or whether it's fantasy, that is wonderful material in order to kind of get blood flowing. And also, again, thinking about just cognition. What are the kind of automatic negative things that we say to ourselves that might inform how we feel every day? Oh gosh, it's never going to get better, or it's always going to be like this, or this is the price I had to pay and I don't have any choice. I mean, those are the kinds of things that often affect how we feel, and we're often not even aware of what we're saying to ourselves. And then the last piece I want to share is that we need to focus on behavior. So when we think about sexual rehab, and when we talk about making a plan and starting slowly, we are thinking about the focus on behavior and action, not just on what we think alone. So that, again, starting with the kind of exercises that might be self-exploration or sensate focus with a partner, whether we're talking about physical activities, stress management, relaxation. These are very active kind of activities that allow us also to regain confidence and self-efficacy. So the point here is that it's a whole person intervention. It's not just about taking a pill, it's not just about focusing on a hormone, but it's about figuring out how to bring mind and body back together, how to identify kind of any negative self-talk and negative thoughts that we have in order to sort of address those, and also to sort of work on the relationship piece, the social support piece as we need to, and then obviously sort of thinking about, potentially medication, hormones, et cetera, as needed. But altogether, it's really a whole person package, and I think that is the key in terms of sexual health rehab. So just to say that there are lots of resources out there, lots of things now in writing, both web-based and hard copy. There are a number of books written in recent years about sexuality and cancer. Sally Kidd, Ann Katz, Leslie Shover have some great books out there. And it's really just important to find the right team of people. So, maybe there's somebody who's doing sexual health rehab in your community. Maybe there's a nurse or a social worker, somebody who's open to talking about it and can help you find the right resources, and also just figuring out what the personal products are that you need in order to help with things like vaginal health, and really using them properly is real important. So I would just say, find what the resources are and use them, and I'm more than happy to sort of be a resource to all of you to help connect you with resources if necessary. So I think I will stop for now and allow us to take some questions if that's okay. Lisa?
Yes, thank you so much, Dr. Bober. I think you probably touched on so many of the issues that we've all experienced, and we've gotten a few questions, some of which you touched on, but I will let you elaborate. Let me take a look here. Okay, so the first question has to do with testosterone. Right. Do you feel that testosterone is a viable option after ovarian cancer or breast cancer, for that matter?
So that's it's a little bit of a loaded topic, but to say that the truth is testosterone is ultimately like estrogen in certain ways, and so in the same way that people are very reluctant to think about using hormone replacement like estrogen replacement, there are similar issues about testosterone replacement for women, especially who had breast cancer. Again, there are individual women who do use testosterone and say that it helps, but the truth is when we look at the larger studies with a placebo versus testosterone, half the women in the placebo group will say they have the same effect as women who are taking the testosterone. So I think the the general, I mean, I'm not an oncologist, I don't pretend to be, but I think the general sense is that there certainly is increased oncologic risk from taking testosterone that there might be with estrogen, and it's really important to speak with one's doctor specifically about that decision. So it is an option for some women, and certainly as for previvors, again, it is an option, but I guess my concern, mainly sort of driven by the research, is that it is not overwhelmingly convincing that testosterone replacement is necessarily what's going to help sexual dysfunction. Do you know what I mean? So it's certainly an option, but I would certainly explore other options as well, because the data is just not that convincing about testosterone replacement for women.
Okay, that's helpful. Okay, well, from testosterone, we're moving on to vaginal suppositories and vitamin E. So
Okay.
We have a question from a previvor who indicates that she was menopausal before her prophylactic surgeries and was already dealing with vaginal dryness.
Sure.
As with many women, she's concerned about cancer risk and doesn't really want to use estrogen-infused vaginal suppositories or creams. Are vitamin E capsules safe and effective?
Yeah, I mean, so typically we don't recommend a vitamin E capsule per se. I usually typically think of the vitamin E oil as something that's that you can put on your finger and sort of insert, but it's probably not going to be as effective as something that you use like with a moisturizer that has an applicator. But just to say that in general, especially for previvors, I think that at least in our institution, and I think in many institutions, vaginal estrogen is considered a very reasonable option. The amount of systemic estrogen absorption from the vaginal estrogens is extremely minimal. And again, I think everyone has to make that decision individually. But just to say that there is no, there's not a compelling argument to say that the vaginal estrogen is not safe for previvors. So again, I don't. I realize it's an individual decision, but I just think it's important that women are aware of the amount of systemic absorption from the vaginal estrogen, which is extremely, extremely minimal. So and there really is. People feel very comfortable using that with previvors all the time. Actually, there are women. I mean, many of our oncologists are very comfortable using vaginal estrogen with breast cancer survivors. So I would just say that, especially if somebody's really struggling with severe dryness, it might be worth considering using vaginal estrogen even short term in order to get the tissue healthier, and then to switch to something non-hormonal.
Okay, great. We have, let's see, when I was on Wellbutrin for depression after cancer, it didn't help my depression, but it helped my desire. Is there any research to support the use of Wellbutrin to help with libido?
Yeah, so again, that's a variable issue. Some women find that it's helpful, some women find that it's not. I think that the research essentially shows that it's mixed. But the point is, if it's helpful for you, then it's helpful. And so, there are definitely some women who do use Wellbutrin and have found that it does have some benefit for desire. The other thing is, again, if you're feeling less anxious, if you're feeling less depressed, that can also sort of have an impact on sexual desire. So again, I don't know that's where it really is a bit of trial and error, I would say. And so when you think about the fact that desire is really impacted by so many different things, if that's something that women are struggling with, I think you need to sort of know that there are many tools in the toolkit and you can try them. And if it works, that's great. And if it doesn't, you don't have to feel devastated, but that, you move on to trying something else.
Makes sense. So we had a question about the vaginal moisturizers and whether which ones are available over the counter versus prescription.
Right. So vaginal moisturizers are all over the counter, in that none of them are hormonal. They're, as they're all non-hormonal. So the vaginal moisturizer, it's interesting. This market is now booming. There's now all of a sudden sort of an awareness that there are many tens of millions of women in postmenopause in this country who have vaginal dryness, and there are just lots of new products sort of coming on the market. And this is not around sort of cancer necessarily, but just about menopause. But these are non-hormonal, so they are all over the counter. They're not all available at all the same stores, so that's where I think you have to see what's available where you live. The other thing is that with the internet, some of these products are certainly available online. As I said, I don't mean to be pushing particular products, but there are some that we are using with women here that people just like a lot and find very really helpful, and often are really notice they're just hugely helpful. So they are generally all over the counter because they are non-hormonal, and that means they're non-prescription.
Fabulous. We have a couple more. Let's see. So we've got somebody who is talking about the fact that she's 7 years post-surgery, unfortunately divorced, and hasn't been intimate basically since her surgeries. And she's not sure where to start. She's not sure how to embark on dating and how to, deal with all the issues. Do you have any suggestions for women who?
Thanks for asking a quick question at the end. Sure. I mean, just the question. Sorry, I didn't mean to interrupt you. The question about dating and how to get started, is that the question?
Pretty much, yes. What's the first step? How does somebody maybe, get back on the horse?
Okay. So, I would just say that in general, a couple of things here. I mean, first of all, getting back after dating, after any sort of long amount of time where you haven't been in a relationship and haven't dated in a while for any reason, it's not easy, right? You need to often sort of take it slowly and sort of put one toe in the water. But what I would say is that, and obviously everybody has, individually everyone has all kinds of different, sort of challenges and concerns about that. But for many women, one of the concerns is that, if I do get back to dating, how's that going to go in terms of trying to have sex again? Because I'm not sure if kind of things are working, And I would just say that from the point of view of sexuality in terms of self-care, for a lot of women, just being able to do some self-touch, some self-exploration, maybe working with either a dilator or a dildo, anything to sort of be able to allow a woman to feel like she knows kind of how she's able to sort of be in touch with her body again, right, in terms of being able to feel sensation, figure out what feels good, what doesn't, whether the vagina is stretchy or not, and how to sort of make it that way. Just sort of being able to sort of do that self-care piece can be very empowering in terms of dating, because you don't have to feel worried about it if you know that you feel like your body is kind of working well enough. So from that point of view, I think it's sort of a self-care issue. You don't have to wait until you're in a relationship in order to address the topic. But the other thing is just from the kind of emotional point of view of what it means to start dating again. I think it's really important just to recognize that, especially when we get to, our adult midlife, everybody is bringing something to the table, and so often women will say, well, I don't know how to bring up the topic, or when do you say something, and, with the almost a feeling like I've sort of gone through this thing, and I assume that, I don't know if somebody's going to want to go out with me if they know I've had this experience. And what I always say is that the bottom line is this is not a deal breaker. If you do start slow, you start, whether that's online or whether that's meeting someone for a coffee, not for dinner, or just a date in terms of meeting somebody for take a walk or have a cup of tea, you don't have to say everything right from the beginning, but that at some point when you put a toe in that water and you say, well, gosh, I certainly have been through a lot in the last several years, and some years ago or some months ago had the surgery or had that procedure, you just say a little bit and see what happens. And if the person that you're with, he or she kind of looks at you like a deer in the headlights and you get the impression that person wants to go running in the other direction, well, you probably aren't going to want to be with that person anyway, And on the other hand, if that person says, oh, really? really? My goodness, tell me more. Then you can say a little bit more, and again, take it slowly. But I think the point I'm just trying to make here is that it isn't easy to get back into dating after a long time, but everybody, whether you or the other person, is going to be coming to the dating relationship and the starting from scratch with baggage, with history, with context. Everybody has something in their past or something in their present that they might be feeling uncomfortable about. And so it's just important not to feel like you're the only one who might have something that you're not sure how to talk about, or you're not sure how it's going to go. And so I think starting slowly, knowing that everybody has some history, some challenges, and knowing that really in the end, this is not a deal breaker. Whether you've had cancer, whether you've had risk-reducing surgery, whether you have scars, that is not what defines you. It's certainly a part of you, but it's not all of you. And so, if that or any of that is what's going to make a potential partner not want to be with you, the important news for you is that you wouldn't want to be with that kind of person. So that's probably how I would start.
Great, thanks. So we've had several questions going back to basically the implications of surgery, many about mastectomy, the loss of sensation in nipples, and the fact that it's very difficult to get aroused without that sensation, and also the feeling of, maybe the mastectomy doesn't look the way, that your natural breast did, and so there's loss of some self-esteem or some uncomfortable feelings about your appearance. I know that you addressed this a little bit, but I guess for folks who are dealing with those types of situations, can you just give us some final words on how to overcome those obstacles?
Sure. The first thing I would just say is that you have to acknowledge that's real. I think that, people made a big deal about Angelina Jolie's article, and, we don't have to talk about the details of that, but lots of people came up to me afterwards and said, well, you know what, if it had only been so easy for me, right? Like it, didn't work out so that my reconstruction looks so fabulous, or I don't feel so fabulous, or what about these scars that they couldn't deal with? And it's important to acknowledge that that is real. But I would just say that this is really where it becomes an imperative, an opportunity to be able to then kind of, in a sense, broaden your experience of whether it's foreplay, sensuality, sexual, sexual experience, in that, if before that was a big part or the major part of how you experienced sensation, etc., it just means that you have to then, in a way, kind of remap, rediscover, reconnect other ways of getting aroused. It doesn't mean that we can't make that sensation come back. We can't pretend things are fine if they're not fine in terms of how, the breast reconstruction came out or didn't come out. But you certainly can sort of choose to make that one's focus, or you can choose to say, I can wear a pretty cami, I can cover up, I can keep a bra on, I can keep a t-shirt on, and still be able to find ways to feel and give and get pleasure, right? So I would just say in a sense, the point here is not that we can make sensation happen when there isn't any, or we can make breasts look better when they don't look good to you. But what we don't have to do is make that be the sort of guiding, frustrating focus of a sexual or sensual encounter. We can really find ways to use camouflage, turn the lights off. You don't have to necessarily find a way to like your breasts if you hate how they look, but you can say, look, they are what they are. What I can do is focus on something that I really maybe don't think a whole lot about, or have I really thought about or felt very inclined to sort of focusing on other parts of my body, other ways of giving and getting pleasure. And so it's really about expanding the repertoire as much as trying and shifting the focus, necessarily then sort of taking something which feels very frustrating and try to make it less frustrating. Because again, if somebody is saying, look, I really used to feel aroused primarily from nipple sensation, I don't have sensation there anymore, I'm not going to say, well, let's try to pretend you have sensation, or let's try to make you have sensation. Well, you don't, and that is a very real loss. But what I would say is that, there's a kind of a limitless way in which human beings are able to kind of to really sort of remap their experience. And so being able to take your time, start slowly with or without a partner, finding ways to really reconnect with other erogenous zones is probably going to be a big part of the answer.
Great. I think we've gotten several thank yous for addressing these issues that so many doctors and just people avoid in general. And I want to let everybody know that Dr. Bober has not only been engaged with FORCE at the local level in helping women, but also has been a guest at the FORCE conference. And we always have a session on sexuality at the FORCE conference. So I would imagine between now and next June there'll be some additional products and maybe some new information, and I would encourage everybody to come and hear the latest updates if they're able to get to Philadelphia next June. So I'd like to thank Dr. Bober, and if there are additional questions that we weren't able to get to, please feel free to forward them to us, and we will try to facilitate getting those questions answered. I want to remind the folks that sent some more medically oriented questions that Dr. Bober, is not your MD, and that those types of questions really need to be addressed, surgical questions, that type of thing, to your doctors.
Yeah,
so,
I mean, Lisa, can I just throw one other thing out there? Especially around things like some of the questions about surgery and hormones. I would just say that, if you do ask your doctor and you're not either satisfied with the answer or unsure about the answer, it's really okay to get a second opinion, because I think lots of times clinicians are not always totally informed about some of these topics. And so just to say that it's really okay, and I think often encouraged from my point of view, to be able to get a second opinion about some of those topics if the first opinion you get is not informative enough.
Absolutely, and FORCE definitely stands behind folks getting multiple opinions on everything from surgery to HRT, and seeing the best doctors that you can find. So again, thank you everyone for joining us. You will receive your evaluation via email tomorrow. We really appreciate it if you would take a few minutes to complete that. And this webinar will be archived on the FORCE website probably by next week. So if you'd like to refer back to it, please visit the website and you'll be able to see it then. Thank you very much, and thank you for your support of FORCE, and have a nice day.
Thanks for having me. Bye-bye.
Thank you.